next slide. Oh,
Grant,
sorry.
can you tell me a little bit about how you chose or when you choose to do a TTO, if you have isolated trochlear defect or if you have a patella defect? What do you use as your decision-making node?
I usually use around 15, but it also kind of depends on the patient. I mean, I see less patients with a large TTTG that have isolated trochlear defects. It may just be my practice. With patella, I'm a little bit more, and I mean, maybe sometimes occasionally if it's a 16 or 17, I may still leave it if it's just an isolated trochlear defect. With the patella, I'm much more aggressive on TTOs, and that's just, I think working with you, but in general, also just sort of my learnings over the last few years in practice too. I just have a low threshold to offset that defect because I find that patellas are a little more challenging with their outcomes. And so I want to give it every possible shot to do well. So usually 15. And then depends on if it's more of an anteriorization, there's no instability, I'll focus more on the anteriorization. If it's more of an instability, I'll do a combined anterior and medialization.
Yeah, I think that patella, especially inferolateral, even a setting of a nearly normal or normal TTTG, is still offers some consideration to unload, just because these are often really load-related defects. So it's not different than correcting varus or valgus. But then you have to question if you have medial proximal defects, do they really ever get unloaded in any meaningful way? And I could argue those are the ones that you might say, look, maybe we'll let those go. But even in the setting of a normal and nearly normal, we've learned that pretty low threshold to do a TTTG or even with, a TTO. Trochlea, we're doing maybe less and less just because the amount of unloading is so minimal.
Yeah, and I would agree that there are certain things. I've had, people that were 14 or 13 with an isolated lateral defect or a low lateral defect, and you just feel much better moving that over because we still know that 13 or 14 is still not normal for some patients. So I 100% agree with that. Next slide. I think we're done pretty much. Yeah, so this is just really quickly for any of the fellows, because I actually making this presentation, this is the only part I had not seen before, this little slide, but it's kind of interesting. So at 0 to 3 months, you can see where the implant's at. So when you're telling people to do certain physical therapy regimens, it's important to know that, even at 3 to 6 months, this is not fully grown back. And so it's something to understand that, you're not fully remodeled till that 6 to 9. And so it's important to understand that they're still gaining the strength and gaining those things. And when you're seeing these patients at their interval follow-ups, that, they're not going to be immediately better in the first few weeks. It takes a while for the MACI to grow back, and it's very effective, but you just have to be patient and understand why you can't do those heavy squatting until 6 months. Next slide.
Yeah, and I think it's always important to understand return to sport has a lot of variables. It's not just biology. It's not just how they feel. Return to sport also becomes a very personal decision. It could be anything from a roster change to a contract to a scholarship to, hey, I don't even like my sport anymore. I'm afraid to get re-injured. So the data on return to sport is pretty heterogeneous for several reasons. But I think from our perspective, we just want to respect the biology enough that we don't torture what we just spent the time and energy to do, and the patients actually, observed over that postoperative course.
Yeah, I completely agree with that. I mean, the number of studies that we've done together with a lot of your patients on return to sport for many of these cartilage things, the range of return to sport is totally different, and why they return to sport, or if they didn't, may not have nothing to do with the surgery alone. So I think we all try to say you're going to return to sport in 9 months, but I've had patients that have taken 18 months because they just didn't really want to do anything, or COVID shut down, and that doesn't mean that 18 months is how long it actually takes. It's just that each patient's different.
Agree. I had a couple of questions just to ask you, if you don't mind. I mean, how many years out are you after your fellowship now? How far?
This will be 3.5.
Yeah. So I'm just curious. If you reflect back to your fellowship and what you learned, what do you think? What experiences do you believe have been? This is good for those, if there's some residents on this as well when they're contemplating doing a fellowship. What do you think have been most applicable to you now as you practice independently?
I think the most important thing if you're a resident is to understand what kind of surgeon do you want to be when you get out. Do you want to be doing cartilage? Do you want to do some complex cases? That's the most important thing. And then you decide your fellowship based off that. But if you're in fellowship right now, or examples of experiences, I think for me, it was really managing these complicated patients in your practice and helping take care of your practice as a fellow that really helped push me to the next level and made me feel much more confident going into practice. doing and doing them efficiently too. Like I said before, before fellowship, you'd maybe done some small cartilage transplants and everything else, but I'd never seen, TTO, MPFL, MACI done in an effective manner. And so for that, that's really important to me that that's even possible to do in one time sitting, and two, that it can be done well. And then three, that patients actually do well, because that's a lot of surgery. And so that's for me is an important thing. And then on the non-surgical standpoint, I mean, when to inject, when to do physical therapy, and then when to proceed with the cartilage surgery. When have you done enough for the patient non-operatively that's like, listen, it's time that we start doing something that's gonna make a change in your actual cartilage. And then I think the other thing of the comorbidities, understanding the staging. You have so many patients that come into your office that want cartilage procedures, and a lot of them don't need it, but they've just been told by friends and family or other surgeons, and you're like, well, this is not the right thing. So when is it not the right thing to do as well?
I'm curious, now that you've been out almost 4 years, when you have a tough case, how do you manage it in terms of, running it by other people and maybe getting some other thoughts on clinical management?
I mean, yes. So, there's even being 3.5, 4 years in and taking on some hard cases, there are still cases, and a couple even last week that I'm like, I don't know exactly the right thing to do for this, or at least I'm going to get some more opinions. So, I mean, working with guys like you or other previous people that I've been at Rush or HSS that I worked with, also co-fellows that I worked with, and then people around the city and the area that do somewhat similar cases, try to bounce those ideas off them and understand. But, even at 3.5 years in and having seen a lot of different things and taking on a lot of cases in practice, there's still things that we continue to find that are different and unusual. And it's really important to be humble, I guess more conscientious for the leadership side of things, and understand that you need to still ask for help or at least get information and make sure you make the right thing. Because in the end, for me, the most important thing is that I do the right procedure for the patient. It has nothing to do with my ego. That's got to go away.
Sure. So, now that you've been out, where in your practice does MACI fit in routinely? What kind of cartilage problems?
So I think in my practice, the number one thing is patellofemoral. Going in, I always heard about patellofemoral is the most challenging one to take on. I've ended up doing a lot more of those in practice because I really wanted to find a way to get good results, but also not burn bridges. So for me, the isolated patellar defects, the isolated trochlear defects without bony edema, and if I have something that needs a condyle and a patella, for me, I'm in private practice, so I do a lot of mine as a surgery center, and we have to be cost conscientious. And so, that I usually do the MACI in combination with those two. And it's important for me also from the MACI standpoint. Again, the MACI and cartilage transplant in certain things are somewhat similar results, at least from the data. I may be biased, but it does help. And I can do these patients as an outpatient. I don't have to wait for a wait list like they do for the cartilage transplants. That being said, I do a lot of cartilage transplants as well. But I think for me, the patella, trochlea is really the workhorse for me for MACI. And I've been really happy with the results.
Steve Bachchan, I have a question for you, and where you are relative to your training. What can fellows do now? What advice would you have to increase their comfort with MACI as they sort of go to the next stage of their careers in practice?
Yeah, it's a great question. I think first and foremost, just getting to the operating room and watching your attendings do it. I think, all the points that you've brought up, I think it's very nuanced. And you can do something, but I think it's important to make it reproducible and make sure you do it well every time. So, not violating that subchondral bone, for example, as you're curetting, things like that. For me, surgery is a very hands-on sport, and watching Dr. Taylor and some others do it, I think in a very well and reproducible manner has really been enough to kind of imbue me with confidence that I could do these procedures initially.
Yeah, great. Grant, any final comments on that before we finish up?
I think that, I think I'm big on videos. So I watch a lot of, View Medis. Actually, with the first MACI in practice, I actually watched your trochlear video, which was kind of cool because I'd, obviously seen it in fellowship too. And so that helped me understand that. But the website's really good. It has lots of good videos. And then, View Medi is amazing. So I use View Medi still to understand. And if I need to do a complicated thing, are there steps there that I can do? And then I'll give back as well. So I'll do my own video and post that on View Medi. But anyhow, so the answer is, I just try to prep as much as I can, prepare for the case. until I feel really comfortable for it in practice.
Well, I think we have a couple of more minutes just to wind down. I'm wondering if anyone, on the panel, Dean, Steve, Grant, any other topics that you might think would be interesting for our audience?
Well, I think the case that you presented, Grant, was really an example of putting what the patient wanted first. And when we talk about leadership at its most basic level in healthcare, you're leading that patient. And it's not about the person in charge. It's more about shared decision making and coming to the right decision for each patient. And what you showed was an example where you took that shared decision making process, took the available technology and the surgical skills that you've developed, and came up with a great outcome. And I think that's what we're trying to do all the time. So, Mike, I have a question for you fellow humans, Brian and Grant, if that's okay. Not all these cases go perfect, do they? And so maybe you guys can share some of your tips on what you do when things don't go so well. And you talked about not burning bridges, Grant, but I think that's a very important process that I've learned, is taking things step by step. But what other thoughts do you guys have?
Well, I think that it's what you don't do when things don't go well is probably equally important rather than what you do. And if it's there's lots of ways that things don't go well. I think the first issue is asking a patient what they would like to achieve if they seek treatment. And I always ask patients that at some point during the visit, say, look, what do you really want to get out of this if you pursue treatment? And then I would say that the part that doesn't go well is when we don't deliver. Patients have a very specific ask. Now, sometimes it's just reassurance, and they don't have much in the way of symptoms, or they need permission to be more active with minimal symptoms, but they've been told they have a cartilage problem. It could be really simple, or they just don't want to have a knee replacement in 15 years, and are looking to your advice to say, do something to me now, despite not having symptoms, so I won't have to have a knee replacement later on. Those are things you really have to get inside the head of a patient. But once you sort of agree that you're going to treat a patient through consensual decision making, as you say, Dean, I think that's what the worst complication that I don't want to have any complications, but the worst complication that's outside the operating room theater is not delivering. All kinds of things can happen. We can get DVTs, we can get pulmonary emboli, we can get post-op arthrofibrosis, but not delivering, for example, a failure to meet their goal of, say, less pain or more function after you've dragged them through 6, 8, 9, 12 months is actually really disheartening. So one of the things that I think a fellowship teaches people is that it sort of provides enough data for at least 5 years into the future. And when Grant interviewed with us, I said, look, those of you who are seeking a sports medicine fellowship, or any fellowship for that matter, this is a privilege because it can provide you enough aggregate experience if you're training with the right mentors. And it doesn't have, and you can borrow from all different mentors in terms of what you take home at the end of the day to propel you 5 years into the future. Because when you think about what our obligation is, why we're put here on this earth as physicians, is to really make a difference in someone's life. And it's frustrating when it doesn't happen. It's most frustrating for the patient, but the next person in line is going to be near you. In the operating room, I think the most important thing is you can't lose it. If things are not going well, it's also very stressful for the staff, the people around you and so forth. And you are really the sort of commander in that setting. And it's really critical to sort of keep your head together and understand that, most trouble that we get in the operating room is you can get out of trouble, and cool heads typically prevail. And once you do enough surgery, it'll be very rare that you'll find a situation that you haven't seen before. And that's one of the things that experience delivers. Again, more reason for a fellowship, because it's much better to see me struggle and get out of trouble than you get out in practice for the very first time and have to struggle and figure out what the heck do you do when you're in that situation. So those are just some things that I often think about. Granted, now that you've been out, have you had any sort of true, I got to change my scrubs moments since you've been out
Yes.
that have really, you're like, my goodness, I don't know how I'm going to get out of this problem?
Yeah. Well, I would just jump into the fellowship portion. I mean, did so many complicated cases with Dr. Cole, and 99% perfect, and we have occasionally ones that we get stressed out at. And I saw him just completely be like this, and I've never seen a surgeon go like this in a case like meniscus HTO combo, and there's like a little blip, and he just doesn't stop. He just chill the whole time. And I was like, if I can be like that in the OR, that'd be awesome. So I'm still working towards that. But definitely in practice, one thing I'd recommend, again, if you get a good fellowship, is you go after the hardest cases. You just can't be afraid. And that was really, like, early on, very stressful. I remember my first meniscus transplant, or my first, MACI combo with a bunch of stuff. I'm like, what am I doing here? But I spent a ton of time preparing, and, didn't go, it's not perfect in terms of the way you saw it happen in fellowship, but the result ended up being good and the patient did well. But there's definitely times that I'm still learning. You still get something, you do a case, and you do a meniscus transplant, or you do some other complicated thing, and you're like, oh my God, I didn't even see that in fellowship. And you got to keep getting better. But that's, again, why they call it practice. The biggest thing is that you don't leave the operating room until it looks good. You keep your cool during the really hard things. And I would recommend to any of the fellows coming out that you just really shouldn't be afraid to do the cases if you feel comfortable doing them, because the more challenging cases you do, the better you will get, and the less scared you will be, and the less frustrated you'll be in the OR. And then you can get to that cool-headed, level-headed person that I got to see in fellowship. So it's just, but it's not easy. And there's nothing fun about your first case when your whole surgery center has never even seen a meniscus transplant. You're like, okay, we're going to do an HTO and a meniscus today. And they're like, what? So, it's early on, it's not the easiest thing, but it pays off the huge dividends in the end.
Yeah, I think those are all wise words of advice from both of you. And Grant, one of the things that I tell our fellows is, when you join that practice, don't be afraid to ask for help when you need it. I think there's a saying that to ask for help is a sign of weakness. I think that's totally mistaken. To ask for help when you need it is a sign of great wisdom. And have you been able to have partners that you've been able to lean on and lend a hand when you're doing some of these complicated cases?
I actually hate to say that. No, it was I was, the positive that is, I got very busy in Seattle, but the negative was there's only a few of us that even do that in the area. So I didn't have anybody lean on. Actually, before I came, there was no one that did MACI, meniscus transplants, HTOs, anything. And now we're doing them as outpatients. So that was a harder learning curve, but I knew that it was a bigger reward, but not having that stuff. But I was able to lean on my co-fellows and those things. And again, the nice thing is that if I something I don't know how to do, I usually do a lab on and I prepare. It's just things I learned from being with Dr. Cole in fellowship, and I was able to make it. Where I was also lucky to have good training with Dr. Cole, so I got to actually see a number of these things actually happen. It's not like it's the first time I've ever seen it, and I know it's possible. Seeing how he does it, he's got a good team. So I just found a way. I'm like, hey, how can I take all the things I learned about and build this ultimate setup? My PAs, everyone I know knows exactly what I'm going to do ahead of time, and that's what he did, and that's been really helpful.
Yeah, it's funny because I had a dry spell recently where I hadn't had meniscal transplants. I don't know, probably 4 weeks, 5 weeks, which for me is kind of a dry spell. and I think because more and more people are doing them, and we're growing a program, and I've got 2 wonderful partners who do meniscal transplants, and they're great at it. So, which is all good. That's part of building a program. So I hadn't done one about 4 weeks, and I look on the schedule, I'm like, oh, I've got a meniscus transplant, cartilage transplant tomorrow. And today I had it, and you remember Kyle, who's one of my physician assistants.
Yeah.
And what he does, he will go in the room 10 minutes before, and it could be a nurse who's never scrubbed with us before, and he will walk through every step and say, he points to every instrument, this is what to expect, and it just lowers the stress in the room exponentially, and they're really fun once you get comfortable, and people sort of are in this rhythm. It's almost like running an orchestra. There's very little stress. And then the reason that's so important is because when you do have a problem, whether it was because of something you did inadvertently or because there's something about the patient's anatomy or other, you have the time and the energy left over. If you're spending a lot of energy to get through a case and then something happens, that can be a real challenge. We only have so many reserves, and I guess maybe as I get older, I have less and less reserves. So I'm always reserving things during the case to make sure that I have plenty of energy if something should happen, and you can respond appropriately. But I will tell you that having a good team around you, these are not cases. I think MACI's easy, to be honest with you. I think once people learn it, I don't think it's a challenge. I think the concomitant procedures, require some judgment and skill, such as osteotomies. But beyond that, the MACI procedure is about as easy as it gets, quite frankly. I think it's when you do other things combined, you're adding meniscal transplant, you're adding osteotomies, you're doing an ACL with it. You only have so much time in the operating room. Having a team that has some experience and judgment, I think it really, that's what makes the case go. And I think that's also in the best interest of the patient.
Yeah.
I mean, both of you guys point that out, that you got to have that team. And that doesn't happen overnight. So for the fellows and those that are starting practice, understand you got to be patient to build that, because you're not going to have Brian Cole's team on day one when you show up at your new job. Steve, that's for you.
But I think you got to set expectations too, right? You come into practice, and I rotate with PAs and residents and stuff, but I have my certain ones that do, like after seeing Cole, like when it's a big procedure, I have 2 or 3 people that I do it with, and that's it. And I have to do it that way. Those are not cases you dabble on. And I saw that, in fellowship. But as long as you come in, if you know what's going to be the hard parts and you prepare ahead of time, I do find that makes a huge difference. And a lot of these cases have gotten a lot less stressful for me because I just badger the team. They know, like, these cases, like, everyone has to be on, like, we're going to be focused for this one. We do ACL, those things, and they're less stressed. But when we have this like combined cases that he did with Cole so often, now everyone's like, oh, we're just doing the meniscus transplant. That's what I want to hear. I don't want to hear people being like, we're doing a meniscus transplant. Oh no.
Well, it's come full circle. We've had a great discussion tonight, and we were talking about teamwork and leading that team and bringing them all together to include the patient as a member of that team. So this has been great, fellow humans, to come together and talk about MACI, talk about leadership. I think we've run over a little bit, so apologies to the audience for taking a little bit of your time tonight, but hope everybody's enjoyed it.
Indication for use. MACI, autologous cultured chondrocytes on porcine collagen membrane, is an autologous cellularized scaffold product that is indicated for the repair of single or multiple symptomatic full-thickness cartilage defects of the adult knee with or without bone involvement. MACI is intended for autologous use and must only be administered to the patient for whom it was manufactured. The implantation of MACI is to be performed via an arthrotomy to the knee joint under sterile conditions. The amount of MACI administered is dependent upon the size, surface in centimeters squared, of the cartilage defect. The implantation membrane is trimmed by the treating surgeon to the size and shape of the defect to ensure the damaged area is completely covered and implanted cell side down. Limitations of use. Effectiveness of MACI in joints other than the knee has not been established. Safety and effectiveness of MACI in patients over the age of 55 years have not been established. Important safety information. MACI is contraindicated in patients with a known history of hypersensitivity to gentamicin, other aminoglycosides, or products of porcine or bovine origin. MACI is also contraindicated for patients with severe osteoarthritis of the knee, inflammatory arthritis, inflammatory joint disease, or uncorrected congenital blood coagulation disorders. MACI is also not indicated for use in patients who have undergone prior knee surgery in the past 6 months, excluding surgery to procure a biopsy or a concomitant procedure to prepare the knee for a MACI implant. MACI is contraindicated in patients who are unable to follow a physician-prescribed post-surgical rehabilitation program. The safety of MACI in patients with malignancy in the area of cartilage biopsy or implant is unknown. Expansion of present malignant or dysplastic cells during the culturing process or implantation is possible. Patients undergoing procedures associated with MACI are not routinely tested for transmissible infectious diseases. A cartilage biopsy and MACI implant may carry the risk of transmitting infectious diseases to healthcare providers handling the tissue. Universal precautions should be employed when handling the biopsy samples and the MACI product. Final sterility test results are not available at the time of shipping. In the case of positive sterility results, healthcare provider or providers will be contacted. To create a favorable environment for healing, concomitant pathologies that include meniscal pathology, cruciate ligament instability, and joint misalignment must be addressed prior to or concurrent with the implantation of MACI. Local treatment guidelines regarding the use of thromboprophylaxis and antibiotic prophylaxis around orthopedic surgery should be followed. Use in patients with local inflammations or active infections in the bone, joint, and surrounding soft tissue should be temporarily deferred until documented recovery. The MACI implant is not recommended during pregnancy. For implantations post-pregnancy, the safety of breastfeeding to infant has not been determined. Use of MACI in pediatric patients younger than 18 years of age or patients over 65 years of age has not been established. The most frequently occurring adverse reactions reported for MACI greater than 5% were arthralgia, tendinitis, back pain, joint swelling, and joint effusion. Serious adverse reactions reported for MACI were arthralgia, cartilage injury, meniscus injury, treatment failure, and osteoarthritis. For more information or to view full prescribing information, please go to maci.com.